Our next speaker up is Dr. Beth Darnall. Beth is a PhD, associate professor at Stanford University School of Medicine in the Department of Anesthesiology, Perioperative, and Pain Medicine. Beth directs the Stanford Pain Relief Innovations Lab and is a principal investigator for an NIH-funded clinical trial on behavioral treatments for chronic pain. She is also chief scientific officer at Applied VR, a scientific member of the NIH Interagency Pain Research Coordinating Committee, and has twice briefed the U.S. Congress on pain and the opioid crisis. Beth is also a brilliant speaker, and we've worked together on several projects, including some of the research she's going to be speaking to you about today. We're happy to have you, Beth. Thank you for being here.
Thank you so much, Dr. Lewis. It's really a pleasure to be here and always to be part of your great conference. I'm excited to speak today about home-based behavioral skills virtual reality for chronic low back pain, and I'm going to be presenting some of our results for 3 months post-treatment for our trials. So let me go back here and just briefly visualize my disclosures, some of which were already described. This is where my research funding comes from and some other associations. So you're all well aware of the scope and magnitude of the problem of chronic pain. Up to 1 in 3 individuals or 100 million Americans are living with ongoing pain of some type. And this is a tremendous consequence, not just for the person, but for their family. It erodes their quality of life, impacts their function often, and also is of economic consequence to the person, to the family, and also to the nation. Pain is not constrained to the United States, of course, and while pain is a very large problem here, we see that similar rates and prevalence worldwide, so it's a global issue. And it remains that pain is primarily treated as a biomedical problem or phenomenon, despite the fact that we know that pain is truly biopsychosocial in terms of experience. And this has been really recognized by multiple government institutes and agencies who have called for comprehensive pain care, better integration of behavioral medicine into pain care pathways nationally. And what you see is that this has been called for really for the past 10 years. But what we've seen is a failure to implement this broad guidance for how pain should be treated. Now, this national guidance comes from a fundamental understanding that pain isn't just a noxious sensory experience. It's both a noxious sensory and an emotional experience, meaning that it is that whole person experience. And psychology and our emotional experience are actually baked into the definition of pain. But as it turns out, we often focus on that first half of the definition and purely and omit the second half of the definition, and then wonder why we're achieving suboptimal outcomes for our chronic pain treatment. So the solution is truly to begin treating pain holistically. I have a slight delay with my clicker, so just one moment. Okay, there we go. Pain is a complex experience that is influenced by a whole host of individual factors, including the context in which we experience it, the meaning we attribute to it, our cognition, our thoughts, our emotions, our mood, all of these different factors, how much attention we're giving the pain. They all have the capacity to modulate our pain experience. And this stands as a reflection of why it is so important to treat pain from a whole person perspective. Apologies for the delay with the clicker. I might ask, oh, there we go. Okay. Regardless of where we experience pain in our body, no matter the location of the experience of pain, it is processed in the central nervous system, that being the brain and the spinal cord. And as such, our experience of pain is influenced by all of these individual factors I just mentioned. And so by equipping individuals with better descending modulation or top-down control, by targeting the brain, we can help people gain better experience, better control over their pain experience. And so while pain is a biopsychosocial experience broadly, we need our treatments to address it as such. This is really the opportunity. Now, historically, the most common, well-studied behavioral treatment for chronic pain has been cognitive behavioral therapy. This is typically delivered either individually or in groups over multiple sessions, often 8, 10, or 12 sessions, where individuals receive all different types of information about how to best regulate various factors that influence pain. And they learn self-regulatory skills such as diaphragmatic breathing. They learn about the relaxation response, cognitive restructuring, and there's some mindfulness factors. I'm going to ask if the slides can be advanced on the Hogue side, as I'm having trouble with my clicker. If the next slide could please be shown. Great. And so individuals learn this whole host of information over multiple sessions, often lasting 2 months or longer. And it's been shown to be efficacious. This was a particularly exciting study that was quantifying the mechanisms for cognitive behavioral therapy and its impact in people with chronic pain. And what the researchers did was they scanned the brains of people with chronic pain prior to treatment, and then individuals underwent 11 weeks of CBT or cognitive behavioral therapy for chronic pain, and then they scanned their brains post-treatment. And what the researchers discovered was that before treatment, people with chronic pain evidenced substantial volumetric deficits in key regions of the brain associated with pain control. But then 11 weeks later, at the end of treatment, they evidenced substantial volumetric increases in those same regions of the brain. And these volumetric increases correlated with patient reports of decreased pain, and they were entirely mediated by patients reporting having better control over the cognitive and emotional experience of pain. And why that's so exciting is people can learn that. People can learn these self-regulatory skills. Next slide, please. And the efficacy of CBT has been demonstrated over 2.5 decades of scientific study. And the accumulation of evidence is such that this expert review and consensus panel that the Lancet put forward in 2018 recommended that education and cognitive behavioral therapy for chronic pain be put forward as first-line treatments for back pain. But that's not often how we treat pain and back pain specifically. Often these behavioral treatments, patient education, skills-based pain management is often the treatment of last resort, where we offer it to patients after they've failed multiple medical treatments, and that is both costly and demoralizing to patients. So what we need is to get into better alignment with the federal guidance, but what we've lacked are solutions that are actionable. Next slide, please. In 2016, we quantified some of the barriers that patients and clinicians experience in attempting to provide their patients with pain psychology or behavioral medicine for chronic pain. And those barriers include too few trained therapists. Sometimes patients, they find these multiple sessions infeasible or they're unwanted. There are copays, there are travel burdens. And so while we can talk about CBT as being efficacious and recommended, very few people have access to this highly specialized treatment. Next slide, please. And so this is really where home-based virtual reality comes in. You've been hearing about how virtual reality is effective analgesia for acute pain, for hospitalized patients and other situations. But our group was the first to translate these evidence-based skills and education for chronic pain management into the 3D virtual reality environment. So I'm going to present to you our first study on this topic. Next slide, please. And so this first study published in July of 2020, and this was the first study on VR for chronic pain. This was a randomized controlled trial. Next slide, please. And this was conducted in individuals who had chronic low back pain or fibromyalgia. And people came into the study and we randomized them to one of two treatment groups. They were either randomized to therapeutic VR, in which they learned various information and skills through the VR headset, or they were randomized to receive the same education in audio-only format. So they listened to that through headphones. They had no visual content, and very obviously there was no immersive experience. So with this education, the skills training delivered through the 3D immersive environment, Dr. Maddox has earlier described the importance of how therapeutic VR engages all of the senses to provide a deeper response, a more engaging response, and most importantly, a more effective therapeutic response. People engaged with one session daily over the course of 21 days, with each session lasting about 7 minutes at a time. So these are brief sessions. The program is standardized and it's tailored to chronic pain. Next slide, please. And so this was a 21-day program where people receive various information, engage in the 3D worlds, and some self-soothing environments to better control their pain experience, both inside the headset and also outside the headset. Next slide, please. And so how well did it work? Well, we were very pleased to see that a lot of the evidence for virtual reality analgesia in the acute pain space, we're seeing that translation for people with chronic pain, where across a whole host of outcomes for pain intensity and pain interference with activity, mood, sleep, and stress, we were seeing moderate to substantially important differences, clinically meaningful differences from baseline to post-treatment. Next slide. And so these are just, I'm going to show you 2 slides, data displays for this program. Over the course of the 21-day programming, you can see the audio only compared to virtual reality. This was actually a really rigorous experiment. Normally, people will compare an active treatment to an inactive or an active control. We were actually comparing the same treatment to itself in terms of content, but we were isolating the immersive experience and very clearly showed superiority for virtual reality delivered intervention relative to audio only. Next slide, please. And so while that slide was showing efficacy for pain intensity, this shows pain reductions, substantial reductions for virtual reality for pain-related interference and activity at 21 days, so at post-treatment. Next slide, please. So with these really promising data, we next moved to innovate a clinical product that was 8 weeks in duration. So mapping on to a more traditional model of a couple of months of delivery. However, one critical distinction is that with virtual reality, you're able to deliver the treatment inside a person's own home. They have total control over the device. It's on-demand use. They can use it when they want to use it. They're untethered from the medical system entirely. So we're actually giving patients control over their treatment, their self-delivered treatment. We designed and conducted during COVID a randomized controlled trial in people with chronic low back pain. This was a national study, and this was double-blind, randomized, and it was placebo-controlled. Next slide, please. And so this 8-week product, this is called EaseVRX. You can see that there's different topics covered over the course of 8 weeks. There's a theme for each week, and then there's different types of experiences that people engage with in the VR headset each week. So you can see there's dynamic breathing, there's pain education, there's some distraction. There were enhanced interoceptive awareness or enhanced biofeedback elements, which I'll describe more in a moment, and mindful escape. So this just gives you a sense of the diversity of experiences which deliberately tap into different content and skills that we are aiming to impart on individuals so that they can have analgesia in the moment, but most importantly, so that they acquire specific self-regulatory skills that have lasting effects because they're essentially entraining the skill set within them. Next slide, please. So we compared EaseVRX to sham VR, another rigorous scientific study design in which both groups receive a virtual reality headset. But while the EaseVRX group had 8 weeks of therapeutic VR, the sham virtual reality group, their headset displayed 2-dimensional images, nature images with audio that was simply benign music that was selected to be not overly stimulating or to impart a specific type of mood state. So imagine that it's like you're viewing a TV screen with nature content. Next slide, please. And so this video is displaying some of the content from EaseVRX that you see over the course of the 8 weeks, and you'll see that there's pain education that's embedded so that people learn about the importance of the nervous system, the role of self-regulatory skills. And this slide is showing some of the enhanced interoceptive awareness, where there is a sensor in the VR headset that detects the rate of a person's respiratory rate. And so as their breathing is changing, next slide, please. As their breathing is changing and slowing, the scene is also changing in tandem to reflect to them in an enhanced way how the calming of their nervous system is altering the environment or this 3D immersive world for a very powerful biofeedback experience. This is just a diagram of the patients that were enrolled, and we had 89 analyzed for EaseVRX and 90 in the sham group. Next slide, please. And we found, you might think, well, if people are getting the sham, maybe they don't engage as much, but actually we didn't find that. We found equal engagement among both groups. Next slide, please. And we found participants told us that EaseVRX was easy to use. You can see here it falls between use of an internet browser and Gmail in terms of ease of use. And this is really important because we're mailing people a headset, they're opening a box and they're using therapeutic VR. So it has to be simple and easy for people to use. Next slide. So how well did it work? Next slide. Efficacy was really fundamentally substantial for EaseVRX. Here, I'm going to present to you the data from baseline to post-treatment, and this is for pain intensity. You can see both groups are trending downward, but we found superiority for EaseVRX relative to sham for pain intensity. Next slide. For pain interference with activity. Next slide. For pain interference with sleep, we found efficacy for both groups. Next slide. And we found superiority for EaseVRX with pain interference with mood. Next slide. And also for pain interference with stress. Next slide. And so here is just a summary of endpoints from baseline to post-treatment at 8 weeks. And what you can see is that across all of our selected outcomes, we see moderate to substantial symptom reductions for EaseVRX that was superior to the sham. Next slide. So what we've been doing now, oh, and I should mention that the post-treatment results were published in JMIR. I believe that was in February. It's an open access article. So if you're interested in seeing those results, easy to download online. And what we've been looking at is the durability of treatment effects, because a lot of people may say, well, okay, while they're using the headset, they're getting this really nice analgesic effect and benefits and reductions of pain interference multidimensionally. But then if they stop treatment at 2 months, do they rebound back, or is there durability in treatment effects? And so this is the critical question that we've been examining. And in fact, what we have found is substantial durability in treatment effects for EaseVRX for therapeutic VR at 3 months post-treatment across all of our primary outcomes. Next slide. And so I am just going to present some of these individual variables. So at 3 months post-treatment, so these data displays are starting at pre-treatment and going all the way out to 3 months post-treatment. So 3 months after people have stopped VR, and what you can see is minimal regression to the mean and continued superiority above and beyond the sham VR. Next slide, please. So that's for pain intensity, and similarly for pain interference with activity at 3 months, sustained durability of treatment effects. Next slide. And similarly for pain interference with mood, 3 months post-treatment. Next slide. Similarly for pain interference with sleep at 3 months post-treatment. Next slide. And then lastly, we see sustained durability and treatment effects for pain interference with stress at 3 months post-treatment. Next slide. So in conclusion, what I'd like to say is that we have conducted 2 high-quality randomized controlled trials on virtual reality for chronic pain, our most rigorous being our last study, which used a placebo control, and we showed not only clinically meaningful benefits for EaseVRX for pain control and reductions in pain interference, but we're showing that these benefits persist 3 months later, suggesting that people are effectively acquiring these self-regulatory skills so that even when they put the headset down or stop treatment, there is this sustained benefit. And this provides some really nice evidence for home-based virtual reality, for virtual reality in the future to be prescribed, for clinicians to recommend the treatment, for it to be mailed to patients conveniently in their homes so that they can access on-demand, efficacious behavioral medicine to best manage chronic pain at lowest risk. And this is really the future, where we have these digital integrated options that meet patients where they are. And with that, I just want to thank all of my colleagues and collaborators at Applied VR. Everyone's listed here, including Dr. Lewis, who is a collaborator on this work. Thank you.
Thanks so much, Beth. Such encouraging news to see that there's treatments on the horizon that can potentially help us decrease opiate consumption in the long term.